Can you all hear us on Teams? Just wave, great. Thank you. Got some quite substantive items to get through now, colleagues. So we'll start with the first one, Integrated Performance Dashboard, report number 3. And I ask the Deputy Chief Exec to take us through the IPD, please.
So thanks, Chair. Just a couple of points to raise in advance before we get into the details. So we've continued our work on the development of the performance report. Committed to setting up a meeting with non-execs last month. It's in the action log. We haven't been able to get that together ahead of the 2nd of October, unfortunately, but it is in the diary for that. So we've expanded the executive summary to provide further information in respect of the key areas to highlight, so that will be obvious. The board will note that where there's further work or investigation to understand the issues behind the data, the report specifies that this, along with the governance and assurance oversight arrangements, which will support the board in regard of each of those items. As part of our review, we identified an aspect of performance which was wrongly assessed as consistently passing in the IPR. That's reported in the documents. That was about waiting list size. This wasn't an issue of the reporting of the data rather than the calculation of the upper and control limits, upper and lower control limits, which are applied, from which we establish the extent to which something's failing, passing, consistently or otherwise. So it's how we apply the performance factor assurance indicator. So as a result of identifying this issue, we did review the IPR to establish whether there were any other areas of the report which were similarly affected. We have identified a similar issue applied to the 12-hour performance indicators, the emergency department. So just those 2 areas identified. Both issues are known to the organisation, therefore I don't think the anomaly has not masked the problem or the need for action, but just wanted to be clear that having identified an issue, we checked out whether there were any others. We've also used the executive summary to report a flag up the coming change in the cancer access target reporting. So just need to bring that to your attention because we'll need to update the information we bring to the board, obviously, for that. And then so that was it in terms of the introductions, Chair. So at this point, then I'd hand over to Tabitha and Jane on the quality and safety section.
Just before I do, just to clarify, Chris, how are the recalibrations? How is that actually done? Where's that done?
The upper control, lower control. So I can't describe that in detail, but if you remember when we first established this, we established quite a technical process that Sam Riley from the national team helped us establish. So we do exactly the same version of that again. I can't describe that here, but we'll make sure that that's clear, particularly in the session tonight.
Okay, sorry, Tabitha, over to you.
Thank you, Chair. So in terms of our patient safety key indicators, I'll start with the serious incidents because we were talking about whether some of our themes are related to safer staffing, which will take as an action. So currently, in terms of our serious incidents, we have 59 serious incidents across the trust, and they're broken down into care groups. And you may not have this on the IPR, but I have it on my governance CITREP. So which I'm looking at. So for example, surgery and critical care, they've got 23, medicine 18, women's and children 15, clinical 2, and corporate 1. Out of the 59, the reason why I'm mentioning the numbers, we only have 12 that are sizable incident, which is serious incidents that have kind of caused harm or we've got some learning from it. So we're actually seeing a reduction in terms of through our monitoring and support for staff. I just wanted to highlight that point in terms of patient safety. However, in June, we had a cluster of 3 never events within surgery and critical care. And they were basically, one was wrong side surgery, retained foreign object on the other, and then wrong implant used on the other one. And we have plans, you can be reassured that there is training. They've also been reported to the ICD. So as a region, we're not like outliers in terms of never events. Across the patch, there's 13 never events, including other trust, and there is training that's going to be done as a regional to see where there's human factors. We've talked about industrial actions. We've talked about COVID long-term conditions. So are our workforce tired? Is there issues that we need to do to support them? So we're exploring all that, and Jane can add if anybody has got any questions to that, because she's leading on the training for those. The usual other patient safety ones are the falls and pressure ulcers. I'm not going to go into them because you're looking at them. If you have any questions, please ask. But I'll just elaborate on the pressure ulcers to say that next month's report will identify the avoidable, which is lapses in care, where we actually not cared, and then the unavoidable, not care, to give a picture in terms of where we are as part of continuously improving those fundamentals of care. Mixed sex accommodation breaches will remain due to low capacity of single rooms. So we'll probably still see this coming through, but we actively try and move patients around appropriately. So we've had 17, which is a lower number than we had last month. I will leave the VTE and mortality to Jane, but I'll go into the patient experience ones. The biggest one concerning board being compliance. So you will be pleased to know that as July 2023, we had 15 complaints exceeding 6 month time frame. But as of 31st August, we've got 6 complaints exceeding the 6 months timeline. So we have a plan to try and reduce that to 0, which we discussed earlier, and then I'll bring a report in terms of where we are. A lot of work has gone into reviewing our process, reviewing the report quality of the reports, which sometimes causes delays. Review of the team in terms of support for the team. So we are working hard to deal with the backlog, and we're not where we were a few months ago. So I'm really pleased to say there's been quite a lot of work put into complaints, and we'll continue to do so. So I'll stop there and pass over to you.
So I suppose never events, all different never events, different area. I've spent some time in that kind of area. We've done some audits around practice, data checklists, etc. And actually, compliance is overall really good. But we were put in touch with a human factors expert, actually by James Ticknam, who's come and has both done a bit of a diagnostic, but also spent some time in data system. Teams would repeat that with the October actual fact and the only thing that has really come out of that work is about distractions, which is not so that's that. In terms of the things that are responsible for the BT assessment, we've moved to special cause improvement. Good and hopefully an upward trend. Last month we discussed how the maternity data wasn't in the same data set because of it badging and nothing else. Technically that's quite difficult to combine. The teams have gone back from a 6 months ago. It was an absolute just can't combine that data, but they're going back to see that. And we have a new BTV started. In terms of mortality, we remain overall trust mortality within our. I'm going to say one thing is that spotted the data that we are not seeing fracture fever for the 3rd or 4th. So that's great to see that improvement is paid off, and that work continues. It's not stopped. The acute cerebrovascular It remains as read for deaths viewed by the budget side of the main team, and there are no concerns around issues there. However, it's quite high number. The new alert for us is one that's only us. It's slightly confusing. It's the supervision. I expect a high number of deaths from the supervision. So it's gone to look as per process at whether the coding is right, and I would my gut instinct is that the coding isn't quite right if we've got supervision injury contusion causing deaths, but we will take that as per process. That's all I'm saying.
Just ask colleagues to speak up a bit if that's okay, because the aircon, some colleagues on Teams can hear us properly. No, it's the aircon check. So, okay, Chris.
Next section, people.
So just want to cover 3 elements really. So appraisal, it remains really challenging. I think as we head into winter, we can't underestimate the challenges that are going to be had in terms of getting through the number of appraisals that are still required. However, we have seen for the first time movement into special cause improvement variation, and I think that is underpinned primarily by some fantastic work within the medical medicine care group, where they've made some huge progress in months. So I do want to recognise the effort that's gone on, particularly the medical medicine care group. We do have the improvement plans from each of the care groups to get them to the 95% compliance as we move into the phased improvement targets over the course of the next half of the year, for us to get to that 95% by the end of March. But it is impacted by things like industrial action and things that add additional pressure on the workforce there. Time to hire, you've got 2 metrics in the report this month. We will be moving to the nationally recommended metrics, which are from vacancy requisition to the offer being made. And that's because that's the element of the process that's actually within our control. It's not linked to notice periods, for example. And so what we've got there now is the 2 metrics. We will now omit the old metric from next month, but just wanted to make sure that you have the transparency there of seeing how we're making that change. It's important to recognise here that change reflects the metric that's included within the long-term workforce plan. So we are consistent there in measuring the right thing. Both metrics though have got continued compliance with the common cause variation, and we've got further improvement programmes planned that are implementing as we speak, to both improve the experience for the applicants and also to speed up the process. So primarily this is around digitisation, automation of elements of the process, and it means that we will no longer have to have people travelling across the county to enable them to go to face-to-face ID checks. That can all be done remotely and online. So final one I wanted to just discuss was sickness absence. We've seen a slight increase, but it's now within the common cause variation. And the main reason for the change in the uptick in that sickness absence is because of an increase in COVID-19 infections within the workforce. We have also got a piece of data quality improvement work that's been started, which is to really look at how we're reducing the number of episodes of sickness that are recorded as either unknown reason or known other. So it enables us to have more granular detail, but also to be able to make sure that the activities that we're putting into place are actually going to target the right areas, knowing we've got better data quality around sickness absence, and the demand for occupational health and wellbeing services continues to increase. What I see there is positive, because whilst we've got the activity and the demand continuing to increase in occupational health, particularly around sickness absence for or prevention of sickness absence and sickness absence for MSK and also musculoskeletal conditions and psychological support requests. What we're not seeing is the corresponding increase in sickness rate, which says to me that we're keeping people well and in work by providing the right interventions.
Thank you, Chair. So I'll take finance next. Key issues to report really around the year-to-date financial position and the work we're doing to drive our forecast and the management of issues associated with the year-end financial risk assessment. At the end of month 3, the trust was reporting that it was on plan, albeit that the plan was a deficit of 15.6 million. The full year deficit plan for the year is 18.3 million, so it's clear that meeting the plan becomes more challenging over the remainder of the year. Our plans, of course, do reflect this, but the importance of rigour in our delivery arrangements and management risk is obviously crucial. It is relevant, of course, that the plan is very stretching with a 5.5% improvement target, plus the system stretch that is included in the position. So the pages 136 to 139 and page 141 of the pack do set out the actions that are being taken associated with these risks, and the associated assurance arrangements will be a major focus, of course, through our Finance and Performance Committee. Specific risks included in the year-end risk assessment remain delivery of care group savings and recovery plans. Our savings plans are being loaded on to our WAVE system, and we're now working to load the care group recovery plans onto this system as well. This provides us with real-time data, genuine objective transparency, and effective real-time oversight of performance and the achievement of the milestones that will inform the forecast. This is important work and gives us an advanced look ahead of the normal reporting cycle. We are working hard to manage the cost and income pressures associated with the industrial action. NHS England did make specific provisions in terms of the income regime applied to the elective recovery fund around the impact of industrial action for contracts up to the end of month 1. We haven't had any further guidance on what will follow for the remainder of the year. So there is a data collection at month 5, so we do await that now. Of course, the output of such a review will inform how we would look to mitigate and manage that risk. So awaiting further guidance on that, and of course that'll be reported into the committee in due course. Delivery of stretch efficiency targets and the realisation of benefits through the system collaboration work streams remains an issue for us. Whilst the Trust is projecting a contribution towards the stretch efficiency targets, at the moment we've not yet factored in any benefits which would be realised through those work streams. And the activity of the Recovery and Transformation Programme, which is operating at a system level. So there's quite a lot of work going on in that place. I'll be looking to provide an update in terms of our assessment of that next time. We're working to update our plans and projections with our partners on those developing programmes of work. Now, the fact that the Trust has a plan for an 18 million deficit in the current financial year and the identified risks to the financial position will result in the Trust seeking cash support from October this year. This isn't something that we hadn't anticipated. The fact that we had a deficit plan meant that we would be seeking this cash support. There is a clear process to be followed in this situation. And it'll connect with the formal process to be operated across our system in respect of any changes to year-end positions, and the board will receive some further information in its meeting later today.
Thank you.
And at that point, I'll hand over to Chief Operating Officer, Chair.
Thanks, Chris. And quite a few bits, so I'll try and be as quick as I can. So the first thing is to draw the board's attention to the point on the page 120 around Queen Victoria UTC. Urgent Treatment Centre, where we'll, for odd reasons of data flow, those data weren't included in previous calculations of our urgent care performance. They now will be, so that's the right thing to do per se. It's likely, if you look at the numerator and denominator, to add around 1 to 1.5% improvement in our 4-hour performance, which is not artificial because those patients are in our urgent care system, so there are real patients receiving real urgent care. So that is a point of noting. The June data, we're in the 6th point common cause variation for 4-hour performance, and the 5th point common cause for 12 hours at 74 and 95% respectively. You'll see the ambulance handover performance vacillates between special cause and common cause variation. The point to note is that the metric in the pack is for 15-minute handover times. The drive nationally now, the 2 flagship urgent care targets for this year are obviously 76% in 4 hours, and 90% for 30-minute ambulance handover. So we will change the data in the pack to 30-minute handover time, so you can see our performance against that, and that may be incentivised nationally. The final thing in urgent care is we have said in the narrative that we've used the word improved in its broadest sense, as in arithmetically, the patients not meeting criteria to reside have reduced from a kind of stubborn baseline of 16 to 19% down to a different baseline of 13 to 15%. So arithmetically, that number of patients reduced from around 100 to 80. But when that's the case, it's nowhere near the 5% that it needs to be. So there are still over 80 citizens in our hospitals today who should not be and should be at a place at or near home. And that's worrisome now, but obviously with a view to winter is something that Aaron and I in particular are working with the system on to try and get some real traction in not meeting criteria to reside, and that will feature in the winter paper that comes to October board. We'll also ensure that not meeting criteria to reside features as an SPC chart in the pack going forward. For stroke, the data in the pack reports validated Q4 performance for last year of an A for SNAP at Furness and a B for SNAP at Royal Lancaster. In the last 3 or 4 weeks, the Q1 data for this year has been validated and continues that A at Furness and B at Lancaster. And at this point, unvalidated with 3 weeks this Q2, then we continue at that A in Furness and B in Lancaster. So that appears to be something we're sustaining. Diagnostics, we've 6 consecutive points at less than the 5% target, which is sustained into July and August. So we're confident that will move into special cause improvement from its common cause variation. There's further work to be done in ultrasound, which is over 7%. And we have a number of things that we're doing in that space. But as I say regularly, we should have a high level of confidence in our diagnostic performance. It is robust and there's some headroom. Right, cancer. So for the 3 more notable targets, the 28-day faster diagnostic standard, or lower in common cause variation, that's now 17 months exceeding the target. 2-week waits in common cause, short of the target in June, but achieved in July and August since. As Chris highlighted, the 2-week wait standards being changed in the context of the bigger cancer target changes from October, but we will keep that as an internal measure because it's a very useful pathway measure for us. And I do want to draw the board's attention to 62-day performance. So you'll see that the performance dipped for 62 days in June, and you'll see on page 153 the spike in patients who received their treatment after 62 days. That's one of those paradoxical back of the waiting list issues where we cleared 3/4 of the patients in colorectal surgery waiting for cancer treatment. So those patients had treatment, but in performance terms, they were towards the end of the waiting list. It is a long, complicated pathway in colorectal. We've also seen a higher than usual number of haematology breaches and a higher than normal level of tertiary breaches at the interface with Langs Teaching Hospital. So we have 2 separate pieces of work looking at those, but we remain confident in the trajectory 62 days. And then finally, in terms of elective care, you'll see the time-based graphs all looking good and in sustained special cause improvement. We do have to alert the board to a 7 to 8 week risk in the specialty of restorative dentistry. We're working with commissioners on that, but that is one of our fragile, indeed one of the most fragile specialties in terms of workforce. And so we're working with commissioners on alternative arrangements for that, but there is a 7 to 8 week risk in there. And then finally, waiting list size on page 159, as I mentioned earlier, that's in sustained special cause concern, did for the first time reduce in June, albeit still in special cause concern. And we do have a new process of validation for patients over 12 weeks. That will be adversely impacted by the industrial action. So we're managing cancer and long wait as well at this point. Our early modelling tells us that we will start to see in February and March some significant pressure in our waiting list size, which may then impact some of our long waiters and it will affect our patients past the indicative review date. there's a whole number of things we're doing in that space in modelling the waiting impact, the clinical impact and the financial impact. But it's important to note that industrial action does affect. Okay.
Thank you. Colleagues, a lot of data there, a lot of information, a lot of mitigation. Know how to read data, even if, as you say, Scott, it shows improvement. There's improvement in the right direction, but we're not meeting targets. So we recognise when we're reading the data that even when it shows that we're going in the right direction, we're still way off target in some areas. And then there's issues around falls, which again are in the data sets. And thankfully, when you look at ulcers, 3s and 4s remain at 0s, but 2s continue to be an issue. It's quite open, that one. So there's a lot of interesting data sets here. You want to go first?
Yeah, I just want to clarify a couple of things with Jane about the we covered equality, because obviously we looked in detail at the quality, safety and patient experience data. The never events, can I just confirm, you said they're in the same clinical area. Was that the same site?
Yeah.
No,
All
good.
3 sites.
I just wanted to confirm because we actually had in Formula Equality Committee, they were at 3 different sites.
Yeah,
And,
they were,
so I just wanted to make sure that
but just the same. Yeah.
yeah, so they were all in theatre as you use. Yeah, yeah. So really positive to hear about the human factors work and the things that have been picked up. The second thing about the mortality one, which we've picked up as well, about the superficial contusional injury, which doesn't mean much to anybody, even clinicians, does it really? Amita told us that that was likely to be related to head injuries, and that's where you say there may be a coding issue that it's been not coded as a severe enough head injury. So that's what we're looking at now. So yeah, so that's what I just wanted to clarify, those 2 points as triangulation between what we heard. I think.
Great. I'm going to go Tony, Sarah, and Saturday.
Just 3, I'm sorry, Chair, 3 things. Seems to be a bit of a pattern this morning. The first one's just about DNAs again. Just a simple question says, do we know the cost in terms of hours lost and financial cost? As it relates to my next question. It's quite a lot of cancellations.
We know it consumes resource. Can I give you a pound and pence answer at this point? No.
Is it possible at some point, not right now, to get a sense of what that is in terms of lost time, in terms of clinicians and
You have to take into account how booking happens and the expected the amount of DNA that's often anticipated can make it very difficult to quantify. So, I mean, it's very hard to put a marginal cost associated with it other than an indicative.
and even an indicative, just in the context of finances that we challenges that are in the system, which is the second one. I'll go on to the
Just
second one.
explain what's the rationale behind your question.
Because I suppose, given that if I'm reading the data right, we've got a 7.6 variation of what we anticipated. The second question is that recurring or is that one-offs? If it's one-offs, that's great news. If it's not, it's building up. It's how we've used resources under best value for the best return investment. So I'm just trying to understand that in terms of.
Yeah, we have to decide what it is that we quantify. So, for example, if it's cost us money, it implies an empty slot. What's the cost of the empty slot? Question. Are there empty slots?
Yeah.
And so forth. Which empty slots are related to DNA? Secondly, there's an administration application, so extra work, but they would be indicative and not ICANN attribute specific expenditure to DNAs per se.
I understand that. So I'll draw a line. All I'm saying is that that is, in inverted commas, however, whether it's indicative, it's non-productive time, isn't it? It means a clinician or someone is sat there. So I went to my outpatients appointment on time and I did it. Brilliant experience. What a great service. A tick in the box again for the trust. But I'm just saying, if people aren't turning up, that means we've got non-productive time that's costing trust money in terms of resources, presumably. So it's just making that point linked to the 7.6. That's in the variation. The third point is just about COVID, really. I'm just getting a sense, is there anything coming down the line? Because you read a lot nationally in terms of concerns that there will be restrictions or new arrangements start to be put in place because the job's challenging with industrial action, let alone another layer of complexity.
So we've not seen anything in terms of, and actually, it's just like thinking I'm speaking
Yeah.
to me, but we've not had anything practical in terms of advice, but we are seeing increased numbers. And that's not just here, but speaking to a medical director in another trust in our region, they're also seeing it. So I think that reflects the national picture sector, doesn't it?
But you're not picking up anything, Sakti?
Yeah, it's we are picking up. The cases are going up, but it's not showing necessarily through critical care or deaths yet. Yeah, we've not picked up anything further than what Jane said. It's all about now vaccination and preventing serious illness at risk groups, and that's being brought forward, which doesn't necessarily directly, other than our staff being encouraged to get the vaccines. At the moment, that seems to be the main sort of focus nationally. And the second focus is on testing. Lots of surveillance has been wound down. So there's talks about how do we better understand this new variant. That's all I know, Mike.
Thank you. Yeah. Similar again, and I was told that they bought the vaccinations forward so that patients at risk or people at risk can have 2 shots. That will take them then through to February, so they get a double cover over winter. So we'll just have to be ready for those when they come through. Okay, I'm going to go actually over to you now, Sakti, with your hand up for a question, and then I'll Sarah and then Liz, and then Karen.
Thank you, Mike. I've just been reflecting on the performance dashboard. There's quite a lot of data, and it's always interesting, and the way that we present and tell the story really is very insightful. But then I also sort of overlaid with a number of comments that have been made around inequality. So I've got 2 points to make. One is around inequalities. And I wondered how we as a trust understand that in our patients and our staff, and whether having an in-depth greater understanding can bootstrap ourselves to some of the performance metrics that we are, going in the right direction, not having a quite breakthrough. So that was the question around, and it may be done elsewhere and it's not made its way through the board papers, but how we as a trust understand inequalities that manifest both with our patients, and particularly patients, but also staff, in terms of access, experience, that may be impacting on our performance trajectories. The second point was very briefly on the stroke particularly. I know it's flagged up as red, but we didn't find anything in there, Jane. And it just raises a flag whether this has got something to do with outside of our trust, because within 30 days has been picked up, whether there are things that we need to interface with beyond the trust's boundaries in terms of pathways in the communities that aren't part of the trust. So those were my couple of points, really.
If Jane, take your second point, then I'll ask Karen to respond to your first point.
And yes, and actually Hugh might also be able to answer. I don't think that's a particular area we've looked at in terms of mortality, but I'll put that back to Amita, who leads on mortality for us, and say is that
Although,
something.
Jane, as I understand it, Sakti, that peak in acute cerebrovascular deaths relates to what happened to August last year.
Yes, I dropped
Yeah,
It seems to have been just something that happened then.
it's gone. Yeah.
It's not actually, as far as we can understand it, it hasn't continued through the year. So, so maybe something's happened in August last year.
But I'll ask the question anyway.
We'll ask the question.
Do you know,
Thank
is that
you.
something that we don't handle on? But yeah.
Okay, and then your first point around inequalities, health population, etc.
So we've used health inequalities information to derive our new clinical strategy, and the clinical strategy delivery plans are cognizant of that information as we start to build service kind of access and service placement and the kind of services we offer. So we have a strategic input around inequalities, around service provision that's developing. We've also appointed Chris, new consultant, who's got that background and experience in health inequalities and population health, who's going to be working alongside our teams, particularly around developing, I would imagine, the relationship with our performance information and what we do going forward to address that through waiting lists, the quality and safety So I think we're at the foothills, exactly, of having a good understanding of the benchmarks now, informing the strategy. Then with Chris's input, linking in with the improvement team and the quality team and the performance team, we'll start to see more and more of that play out. We've taken some steps, particularly through COVID and now in COVID recovery, as Scott articulated. When we start to see waiting lists grow and we have to cancel patients, we are more cognizant now and have a more structured view of quality impact, equality impact, so we make sure that we're building back services to take that into account. So I don't think it's visible enough at boards yet that shows that kind of visible triangulation, how it's using to drive improvement or performance. So I'll ask the team to pick that up as we build kind of our information, but we've definitely got a better sense of it and how it's going to inform our service provision going forward. But I know Jane's been absolutely front and centre of this. So Jane, I think.
So yeah, so Chris started, I think, is in week 3, and I think so when we interviewed and we asked what the impact of a public health consultant was on a trust, he gave the most superb answer, and it was just to make you think differently. And I think that's where we're at, is about that starting to think differently. And so I had an interesting conversation with him last week, and he's actually only across the corridor at the moment, but interesting conversation last week about DNA rates, just as a random thing, and he said, so have you plotted distance from hospital to DNA rates and all of those other things? And actually it's about that. So we've got lots of big pieces of work coming up around outpatients, around whole system flow, around clinical strategy, and it's about making us think about those things as we and anticipate that as we build products for the future, I guess, really. So I think we're probably not in a position where we can articulate where we were, and we probably just need to start looking at that better when we go forward. So.
Just to augment that, Secretary, as you know, with your council, actually, we've done some. So what have we got here? We've got some impressive work which has been recognised nationally on the Set for Surgery programme, and Wendy Craig, our clinical director in surgery, and colleagues in primary care and others have done, and it's moved on. It's not about its third or fourth iteration of that, and then with it, we're one of the few trusts in the country who's formally looked at the, just in one tranche of the industrial action, looked at the inequalities aspects of patients that were cancelled during industrial action, and actually something I was surprised by the data. They didn't show what I thought they may have intuitively have shown. So I think we've got the intent, we've proven we've got the systems to do it, and we've got bespoke pieces of work. I guess the challenge is, have we systematised that? I think no, but I think we're half a step ahead in being able to do that, I think.
Thank you. That's really reassuring, colleagues. And just to provide some more encouragement, I think, or reassurance, we probably now a trust I've seen a number of others, performance dashboards and so on. I think we are in a better place to do this, given our experience and also some of the new recruits that we made, and very happy to collaborate. And, you know, that's an offer of support, really. Thank you. Thank you, Chairman. Thank you.
Okay, thank you. All right. Thanks, Sakthi. I'll go Sarah, Liz and Karen.
Thank you. 2 quick ones. Sorry. The first one was just, Scott mentioned the change to the ambulance handover time metric to 30 minutes, 90% in 30 minutes, I think you said. So my question just on that quickly was, when will that come in and what's the likely impact? Do we know what that would look like?
So it started now, and our performance is 83% against the 90.
Okay, and will that be in next month's IPR? When do we start seeing that?
So there'll be a lag because of the retrospective data reporting, and so you should see that November, December, yeah.
Okay, thank you. And then the other one relates to the friends and family test, specifically relating to inpatients, because that's the one that's bringing us down, I think, in terms of our overall performance. And when we look at that SPC curve, although it's on an upwards trajectory, if we drew a line between 18 months ago and now, we've got a long way to go, I think, to get that to the target of 94%. And so really what I'm looking for is some assurance around, do we know what the real challenges are for inpatients in terms of what's driving that data, and what are we then doing about it?
Thank you, Sarah. Yeah, we do kind of know what's, you know, what the impact is. One of them relates to staff and the acuity of patients who are on the wards, which then impacts on people taking time to complete the data. But we can assure you and board to say that we are actually looking at it and trying to find if we can find another method of feedback other than the current friends and family that we've got. So we're doing a lot. We are very, very much aware that it's lying on the 77 rather than, and sometimes 83. So it's not really hitting the mark, but it's based on acuity and time and staff time to really focus on that.
So it's partly about getting responses,
Yeah.
but then in terms of for example, poor feedback, I know we do receive these reports of quality committee, but I'm sort of just reflecting that actually this is going to take a long time to fix. And so if we know that things like waiting times and acuity are going to impact, but actually where it's around poor perceptions of care or staff behaviours or there might be different things. Really making sure we can focus on those things that are much more within our control to change and shift, perhaps.
We'll pick that one up, but we are aware of it, and I can assure you we're working on it. We're really looking at how we can do it better than what we're doing at the moment.
Comes through quality.
Yeah,
Yeah, I was going to say
so
something.
feedback to quality.
Yeah, exactly. Thank you.
Thank you. Did you want to come in on that? So one of the objectives talking to Tabitha is our patient experience strategy. And there is a lot in there around civility and the environment and the timely access to service. So some of those areas we're aware of, like the long waiting times, like the delays, like industrial action impact, which does lead to poor experience and poor feedback. So I think we can be more explicit, Tabitha, about the actions that we're taking under that patient safety, experience strategic approach, because we know what the issues are largely. So I'll ask Tabitha to pick that up specifically to make sure that in the quality committee we can see that cause and effect narrative.
Thanks, Sarah. Please.
Thanks. And apologies if this comes up at quality committee, but under pressure ulcers, Tabitha, you said in the report that next month they're going to be split between avoidable and non-avoidable or unavoidable. How can a pressure ulcer be unavoidable? It just seems counterintuitive.
Okay, it depends, because the avoidable is where we have lapses in care.
Yeah.
So we've done everything, we've risk assessed within a timely manner, and we've provided protective mattresses, and the pressure ulcers kind of happens. So we've done everything. So that one will be the one that's unavoidable if it does happen. The avoidable are where we've lapsed on the risk assessment times. We've not provided the protective measures to safeguard the person. So we will be able to do that through risk assessments, really, and what we have done through the care planning and risk assessment process.
Okay, great, thank you. And then just if I can, Chair, when we look at the delays in discharge, do we then link back to any harms that have happened to that patient? And is that visible when that data goes up to the ICB? Because I'm just wondering, is there a pattern across the whole patch? Because we know the Lancs and South Cumbria struggles with places for patients to recover once if they don't need to be in hospital. So as a patch, how is this affecting,
Yeah, I'm looking at it because we've just actually picked it up through our Humphrey meetings, because the patients who kind of do not meet criteria to reside, normally when they're on a ward, staff think they're well enough, and we've noted a risk there that we may not be paying the focus that we need to. So there is a bit of correlation. So we're looking at it and making sure that if somebody's delayed discharge, they're still looked after the same way, like, they're not medically fit, if that makes sense. So we are reviewing that through our Humphrey meetings and actually looking at the ones who do not meet criteria to reside, because that goes into nutrition, to falls, to pressure ulcers, to everything. So our continuous improvement is going to ensure that that cohort of patients are not given the care and support that they require whilst they're waiting to move on.
I think there's an additional action there. So where we're looking for ICB colleagues in partnership to support us on the not meeting criteria to reside reduction. That narrative that's just happened there, I think, would be a powerful kind of play on cost and harm and experience. It's not just performance delays that the speech is within. So Tabitha, it might be helpful to speak to chief nurse colleagues in the provider collaborative just to get a composite view, because I think it'll help in those system conversations at Recovery and Transformation Board as to what would we see improve as a result of getting everyone down to the lowest number we can for those patients that don't need to be in hospital. I think that's powerful.
It does, it focuses the eye, doesn't it, when you look at it globally across the whole area.
Thank you. Thanks, Liz. Karen?
Thank you. Again, one very specific one for Scott and a broader one for colleagues. I think, Scott, I joined the provider collaborative briefing on earlier this week, and I was really struck. I think it was Chris Oliver who was describing the number of patients who were ready for discharge, but actually homelessness was the biggest challenge. And I'm just wondering, within our no longer meeting criteria to reside, how big the homeless cohort is and what that means in terms of how we might assist and address that.
It's not huge for us. We report it every day. So the not meeting criteria to reside cohort are codified every day, and the housing is a distant kind of fourth or fifth for us. So it's still relevant. It's still a handful of patients, and it's still important. But it's not up near the top. It's almost about 2/3 plus are access to domiciliary care. But we do codify it, and there are bespoke pathways that if it is housing that was started early, and particularly for South Lakes, there's a slick route into housing that works well when I speak to the team.
And my broader question is, just looking at the IPR data, and given my own clinical background, if I look at it through a children's lens, I find myself thinking, oh, what is the equalities picture for children? So when we look at the paediatric surgery, paediatric TNO, paediatric ophthalmology, and I wonder how much paediatric data might be hidden inside other data sets. And then also the paediatric DNA rate running at 14%. I'm kind of thinking, what does this merit a specific look at services for children?
So in the care group performance reviews, we get into that detail. So the clinical director and the nursing lead for children would both agree, and hence if you went back a year and saw the care group performance pack for women and children's, it was almost exclusively maternity, and then with the maternity neonates, it's now maternity neonates and more children's metrics, and it'll evolve further. We have got the next phase of that to go. So the specialties you mentioned, you're absolutely right, because they are buried in the broader elective waiting times, and so they are kicking the door down on it. We're minded to change the packs. There will be some specifics come out in terms of peds surgery and peds trauma and orthopedics. Those are fragile. So I think the points were made. We've got a line of sight to it, and we've got a plan to try and. Will it be in the broader performance pack? I'm not sure, because it will then make that bigger, as Chris said earlier. But it is absolutely done monthly in here.
There was also a regional piece of work with the electric care recovery group and inequalities, and particular paediatrics has been drawn out in that. But we did do a small piece of work around pediatric surgery. We didn't highlight that they were not the right term, more badly treated than other people on the waiting list at that point. But that may be because it was small in numbers rather than. But yeah, so there is work to do.
And the DNA outpatient rates for children, it's not difficult to link those with cost of living, family patterns, working, travel, everything that we talked about here on a number of circumstances. Will that feature specifically in the outpatient transformation programme, the paediatric experience?
I would presume so, but we're just about to talk to people about what those individual fits of work look like. However, for any child who is not brought to an appointment, there is an incident raised, so they have oversight of that as a care group and follow up with primary care, safeguarding, etc.
Thank you, colleagues. I've given this item nearly an hour. Only because IPR is important, it's assurance, you know, we've got to give it some good beefy weight. So just checking with colleagues, are you happy that you've interrogated the data? You're happy that things have gone through the right subcommittees? There's no outlying assurance questions before I move on. Colleagues, thank you. Then we'll move on to 92.2 minutes of the 3A reports from the assurance committees. Liz, we start with audit.
Thank you, Chair. This was a special meeting to consider the annual reports and accounts from the external auditors for the year 22-23. The auditor's report highlighted two significant weaknesses. The first was related to financial sustainability, and this was about the significant underlying deficit and the need to deliver the very stretching efficiency programme in 23-24. There were two improvement recommendations made, which are identified in relation to late adjustments to the draft accounts and income from the Trust's main commissioner. The second significant weakness related to the segregation of duties of controls within the financial system. That will be dealt with when the Trust moves to a new financial system during 23-24. The auditors concluded that the significant weakness in relation to stroke clinical governance arrangements had been lifted, and therefore that was not recorded this year. There was no significant weaknesses identified in the improving economy, efficiency and effectiveness area. And the auditors acknowledged that the Trust had made good progress in addressing the recommendations in the key regulatory reports from the CQC, NICE and the Royal College of Surgeons. That's it.
Questions? Paul?
Not a question, just confirmation of the next steps that were taken following the audit committee. The annual report and accounts were sent to the parliamentary clerk and they were laid before Parliament yesterday. Those have now been loaded up to the NHSI portal and will be producing the annual report and accounts on our website ahead of our annual members' considerations.
Thanks, Liz. We're still with you on finance and performance.
Yeah, so I chaired the committee whilst you were on a holiday, so I'll deliver the report. The alerts were the fact that the financial outturn had been redrafted and showed a deficit of 33.9 million, 15.6 million adverse to plan. This was a deterioration of 7.8 million compared to month 3. The forecast position included recovery actions from the care groups, and there are further mitigations in place to cover those centrally with reserves. The committee was also alerted that we would seek board approval for the application for accessing cash support, and that's later in the meeting. And the committee was also alerted to the Trust block contract arrangements for 23-24, and that teams were working through the implications from this, and a further report will come back to the committee.
Please. Comments on that report?
Just to clarify, Chair, that the forecast that is presented is at this stage of the year forecast for assessment. You would need to go through a process whereby we validate that formally through the Trust board if we're changing. There is a lot of work, some of which is identified in IPR and things that are being done to address some of those risks, but we will bring that through our normal review cycle.
Okay, thank you for that. Okay, happy to accept those reports. Hugh, over to you for the quality committees.
A couple of issues, Chair, that haven't already been discussed. We had a report from the quarterly reports from each care group. We had a couple from the medicine care group. Highlighted that report that Kendal Urgent Treatment Centre has experienced over the last year an increase in attendances, and actually particularly during the winter, which sort of bucks the enormous trend of having higher numbers in the summer. And also that's been associated with an increase in acuity of the problems, so if you like, severity of the problems that have been presented. And that does actually lead to increased risk really associated with that, because the staff are obviously the treatment centre out. This isn't a full A&E. It's just an urgent treatment centre, and we're getting the identification. The initial look at that has suggested these are walk-in patients. So it's not that they're being sent in necessarily by GPs, or certainly ambulance system has a process whereby they certainly don't bring certain cases to Kendal Urgent Treatment Centre. So the medicine group's exploring this in more detail, and that will have implications for the staffing numbers and capability of the staff in there. It may well have implications for that when they looked at it. So that was something that we weren't aware of before, and I think it's important the trustees, the board is aware of that. We received the update on the trust's progress in reviewing and implementing NICE guidance. The board may or may not remember that at previous report there were a large number of guidelines that were overdue their review date. But there's been significant progress in this. In September 2022, there were 243 guidelines requiring which were overdue for review. And at the end of July, that number has been reduced to 113 out of the 535 guidelines that are relevant to the trust. Large number. The aim is to reduce the number of guidelines overdue for review to 0 by March. So there's still quite a piece of work to be done, but it's going very much in the right direction. And also we received an update on the trust's clinical audit programme. It's progressing as expected. Number have been removed from the plan, but that was perfectly the explanation for that was perfectly acceptable, in that they were either duplicated elsewhere or they were no longer applicable to the trust.
Thank you. Colleagues happy to accept them? No. Thank you. We'll move on then to item 93. This is a really meaty item as well. Positive difference annual report. Ali?
Thank you. If I start, and then Tabitha, I'm sure will want to kind of come in from a patient perspective, because whilst this is under a people aspect of the agenda, actually it incorporates both the workforce and the patient elements around equality, diversity and inclusion. It has been through both the People Committee and the Quality Committee, and it covers the period of financial year 22-23. This is a requirement for us to publish the annual report on the website to comply with our public sector equality duty under the Equality Act. So just from very briefly from a people perspective, you'll see that this includes the national reporting around Workforce Race Equality Scheme, which is the RES, and the DES, which is the Workforce Disability Equality Scheme, and also the Gender Pay Gap reporting. There are some additional reporting requirements that we've put in there for ourselves, which aren't actually statutory mandatory requirements for a national reporting perspective, but we think that they are a positive way to show transparency around the equality and diversity inclusion picture for our workforce. So we have an EDI improvement plan for our workforce areas, and the action plan is within the reference pack in one of the appendices there. That shows the year 1 activities, and we recognise that this is a multi-year programme of work to really change and shift the culture around equality, diversity, inclusion from a workforce perspective. Really important for driving the ambition for us to be a great place to work, so important that we continue with this on a not just an annual basis, but we see this as a kind of long-term programme. The forward in the report actually references the national EGI improvement plan, which was published recently, and that has now been it's got 6 high impact changes within there, and we've now cross-referenced all of those 6 high impact changes with our own plans to make sure that we're taking forward actions that are appropriate and relevant to delivering the national EGI improvement plan as well. I need to highlight one transcription error which we will correct before publication, and that is in relation to the ethnicity pay gap. So for the eagle-eyed amongst us, the table on page 196 of the reference pack will actually be replaced with the more detailed table that's on page 244, which is actually the accurate data. So there is a transcription error there that we will correct prior to publication. So as I say, it's been considered at People Committee. It went through the subcommittees in advance of that. Quite a lot of detailed discussion and debate at the programme board and then also the People Committee. And I know it went to Quality Committee in July. So I don't know, Tabitha, if there's anything from a patient perspective that you want to add?
Thank you, Ali. You've highlighted everything that we work from a patient perspective. So looking some of the issues we've already discussed around how we sort of report on our patients' data and highlight the 9 characteristics within that. And then we also have a focus on our learning disabilities patients and what support we give if they're coming to be admitted within our organization. Is something I am actually saying is not mature in terms of me being here a few months, but it is something of focus, and we will continue to ensure that people are treated equally and included, and their care and treatment reflects their cultural background and ethnicity.
Thank you. You've got the report, colleagues. Sarah?
Thank you. I really enjoyed reading this, actually. It was really great to see all those initiatives being pulled together in one place. So because a lot of it goes through People Committee, I think we don't always see it in quite the same way. So really appreciated that. I don't think I picked up at Quality Committee when we saw it. One of the metrics, which is around improved patient access and experience, which in the reference packs, page 191, one of them is about people's complaints about services are handled respectfully and efficiently, and we've said we're achieving in that. And I just wondered if we're confident really or assured that that's the right outcome for that metric, given that it's come through in the CQC report. We know we're not in the right place with complaints, so it's really just making sure that we've got that quite right.
We'll have a look at that, Sarah, because you're right. Because in terms of our complaints and our files, we are not where we should be. So we'll have a look at that.
So I can't answer which organisation, but ordinarily the EDS is actually peer reviewed. So we submit something and it's peer reviewed by another organisation. And we've certainly done that from a workforce perspective. I don't know which organisation has been used from a patient perspective, but maybe we can provide that clarification.
Yeah, thank you, because it may be about the questions that were asked, but it just feels a bit out of kilter with actually what we can see in our own data. So thank you.
Any further questions?
Thanks, Chair. This did go to People Committee, and we did have a really positive discussion around this. And I need to thank Ali and the team for putting together. It's a significant piece of work, this, isn't it? Really. There is some really good stuff in here, some really good progress, but there's also some areas of sustained unequal outcomes, and those are consistent and long term, aren't they? And just to continue with our EDI and health inequalities narrative that we've had that's run through today's discussion, I just wondered whether executive team members found that there was enough visibility of those outcomes through the reporting structures that we've got within a care group and a team level, and whether we need to perhaps be appraised of those with more detail through our IPR reports, for example.
So we can certainly look at that, Adrian. I think one of the challenges with this is that a lot of the data is based on an annual cycle. So whilst there are some data metrics that we can use and data points that we could use, which would be monthly, and we could break them down to care group level, a significant proportion of the data that we use for both the RES and the DARES come from the National Staff Survey, which is obviously completed annually. So we would have to think about how we reported that and whether there was maybe a phased implementation where we do what we can now from the perspective of the data that's available on a regular basis. Because I know what I don't want to get into, it's a challenge already for getting completion rates of the National Staff Survey. I'm kind of conscious that we don't want to get into kind of the survey fatigue scenario, but we'll pick it up and have the conversation. We'll certainly take it through the culture inclusion group.
that would be great if it went through the culture and they could perhaps make recommendations to the people committee on this. Thank you.
Good call, Adrian. Thank you. Any other points? I think we echo it's a good report. Ali, please pass our thanks on to all those who compiled it. Okay, we note the national submissions then and approve and support the annual report and action plan. Yeah, thank you. Item 94, provide a collaboration update. You've got the paper, Aaron.
Yeah, so a limited meeting in July, no meeting in August for the Provider Collaboration Board. The July meeting coincided with a period of industrial action, and we will meet again later this month with a full agenda. Progress over the summer for the Provider Collaborative Board is focused on 3 key areas predominantly. One is really understanding where the respective financial positions are in each provider trust and where does that put us alongside the ICB to give a system view of financial performance. Chris, obviously been appointed recently as the lead finance director for the Provider Collaborative, is working on an approach to forecasting, on creating plans for next year and a route map, for want of a better phrase, to making sure our underlying expenditure run rate is reducing as we come out of this year. It's a really good piece of work. So we'll be working with the Provider Collaborative leaders on trying to get that in place across all organisations. The second area then focusing on Martin Hodgson, who's the lead chief executive for the clinical integration work stream. There was a session, I'm probably going back 4 weeks now, on a Friday with chief operating officers, chief medical officers, chief executives and others, to really start to consider how we push forward with our clinical service delivery ambitions. We've got the clinical strategy, which talks very generally, doesn't it, Jane, about network of services and hub and spoke arrangements and making the best use of technology and workforce in the future, but it lacks detail enough for commissioners to support and for plans to be produced. So I'll be working in my new role with Martin and ICB and the chief operating officers and chief medical officers to turn that into a delivery plan. How can we get agreement well enough to push this on then? So things like the new hospitals and others, we're really clear on the service provision and service consolidation in those areas. The third area of focus has been the central services work programme, which I chair currently. Colleagues will be aware that the hosting arrangement, the target operating model, has been agreed by the Provider Collaborative Board. We're now in the process of seeking which trust in the Provider Collaborative wants to host that hub. That panel will meet the week after next. I'll share that panel with chief executives and a NED from the ICB. Obviously, the chief executives from providers who haven't submitted an expression of interest to host. We should look to make that recommendation at the end of September. We'll then move to progress then with the target operating model being established, the transfer of service and the transformation programmes that follow. I've asked Ali to be the executive lead for UHMBT in that work programme, and Ali's establishing a more structured internal oversight group so we can connect professional leads, trust management group and exec group and board on the progress of delivery plans for the central services work. And then the final point I'd raise, Chair, on the Provider Collaborative is that of the elective care recovery group. Scott's articulated quite a few areas that are changing with targets and more assurance needed. Chris has articulated the impact on finances around recovery and industrial action. So there is a lot of work to be done in that space. We're testing that infrastructure a little bit. Scott articulated restorative dentistry as being a real issue for us locally. We want to see what the power of the partnership can give us in those spaces for improvement. So whilst the board hasn't met through the summer, programmes of work with officers has been continuing. I think September will be quite a full agenda, Chair, for us to progress with an updated board again at the October session.
Great. Questions to Chief Exec? No, okay. Policy and publications report then, item 95, anything outside of, no, okay.
To highlight.
I've got 2 items under any other business. Quick one, over to you, Scott. Quick update on RAC.
So you'll have seen the multiple covers in media and RAC. I won't try and unexpand the abbreviation.
Aerated concrete.
Concrete with bubbles in it. There's an ask from NHSE in a formal letter to the trust to examine our sites for the presence of that concrete, and we do have any to come up with a plan. And there's a whole infrastructure for the plan nationally. There was a survey done on our sites in 2022, which confirmed that we don't have any of that material in the trust. At that point, there wasn't the current level of scrutiny or concern, and so I'm unclear as of today whether that went through a committee process, because it may not have needed to at that point. Now there's an express ask to do that. So we'll dust that down, and if it doesn't go to a committee, we think it will, we'll take it to the appropriate one for sign off, likely via health and safety. But early intelligence is that there's nothing to be concerned about at this point.
So that's our message to staff, patients, families and the public.
Absolutely.
Okay, thank you. Anyone does that? Yeah, thank you, because Adrian raised it earlier on. Go on, Liz.
Does that relate to any areas that we deliver services out that might not be our building?
That relates to buildings that we own as a trust facility.
Right, but we could have issues if we deliver a service in a community building, say, that may need to close or something.
Hypothetically, that's a possibility, yes.
The landlord
Well,
would be
I guess
responsible for checking.
as it would be if the roof fell in, just so I guess that's a risk. That risk isn't heightened, I guess, in terms of RAC. There's a risk of business continuity in any
Yeah.
building that we have.
Yeah, so we may just need to re-sign things if that became an issue.
Yeah.
Okay. Okay, thank you. Comfortable with the RAC update? Okay, my last point is this, just to note really that this is the deputy chair of the board's last board meeting formally. And you will note on the agenda of the private board there is some space for Liz to give us some reflections on her time as a NED. So I'm interested to hear what you say. But I just wanted to formalise in the minutes really our deep appreciation and thanks, Liz. You've been here for 6 years. You know, you've been on the board through COVID, through recovery, through the systems oversight framework. You absolutely phenomenal. You continue your work both as chairs of the subcommittee, but also as deputy chair of the board itself. So on behalf of the board, I just want to formally thank you and just ask colleagues if anybody wants to say anything before we move on. The reason I'm moving on is because you're the next meeting. Anybody wants to say at this point?
So Liz, I think Mike said quite a bit, but our tenures have kind of mapped as chief executive and deputy chair. So I'm just incredibly grateful for your counsel. Your lines of question are always really pertinent, really focused on the key issues. You really help the executive team kind of get to where we need to get to. I think you've been a real steadying hand. I think when we've gone through some real difficult circumstances, whether urology, TNO or similar, and Mike's articulated some of those. So you'll be sorely missed, actually, not just, I suspect, by your NED colleagues from the board, but the executive team really appreciate and enjoy your company and your challenge. So we're going to have some big shoes to fill, I think, but just a personal thank you from me.
Very welcome.
We should appreciate it.
Mr. Cake, Liz.
The corner.
Lorraine as lead governor. Hello.
Hello, I'd just like to reiterate what you've just said about Liz. I've always found her very approachable, very knowledgeable, very personable, and I'm sure that the governors, I speak on behalf of the governors to say thank you, Liz, for all what you've been to us, especially like myself, who's been here nearly as long as you have. Thank you very much, and I wish you all the best.
Thanks, Lorraine. Okay, colleagues, you've got the attendance monitoring, the schedule of business. No urgent business being brought to our attention. I'll close the meeting then at 11 minutes past 12. Are colleagues happy if we reconvene at 12:30 for the private trust board? Yeah, brilliant. Thank you. Thank you, colleagues.
Thanks, folks.